Good morning and welcome to our monthly peripheral webcast number 8 from Mount Sinai Medical Center Lab 6. It's 8 o'clock a.m. Eastern Standard Time from New York City. Please log into our webpage, www.peripheраlinterventions.org, www.peripheраlinterventions.org. And please post your questions to info@peripheраlinterventions.org, info@peripheраlinterventions.org. Good morning, Dr. Krishna and your team. I understand that we have an interesting case this morning. Can you please describe the case that we have?
Well, I'd like to welcome everybody out there who's watching, I got a really interesting patient here who happens to be someone near and dear to me because he basically from the area where I'm from in New York, and he's been suffering with ulcers of the foot. That's basically been occurring bilaterally, both in his right and left foot. I'm just going to go over a little bit of the history. Can you put up the history slide, guys? He's a 69-year-old male with past medical history of hypertension, hyperlipidemia, diabetes type 2, peripheral arterial disease, who presented with recurrent ulcerations of his foot to his podiatrist. The podiatrist had done everything that was possible in terms of wound care, as well as in terms of doing grafting and apple grafts and all different types of things, antibiotics, debridement in order to heal the wound. Unfortunately, he had been fighting this ulcer for many years now, probably about, actually no, I wouldn't say many years, probably around 6 months at this time. But the problem is it's been progressively worsening and it has not been improving. He was sent to an outside physician in Brooklyn who had done angioplasty of his bilateral SFAs, but had documented severe infrapopliteal disease. He was then sent back to his podiatrist. The ulcers continued not to get better, and he also had a lot of pain in his foot. So he came back to, when we saw him in consultation, we went ahead and decided to go ahead and bring him in for an angiogram. We did an angiogram at that time. This was about a month ago maybe. We had on his right foot, the SFA stent had been restenosed. We went ahead and did angioplasty of the SFA stent, and what had happened was at that time was complicated by a contained perforation for which we had to put a covered stent. So our plan at that time was to go ahead and do SFA angioplasty as well as to revascularize his infrapopliteal on his right side. Since he had this complication of the perforation, he was doing well. He had a little bit of pain, of course. Once we were able to tamponade it and put a covered stent in, we sent him home, but his foot became progressively worse within a week to 10 days. He came back at that time, and as you remember, Dr. Wiley, you yourself did the revascularization of the peroneal, and now, currently, he feels great from his right foot. The pain has subsided. He's very happy in terms of that. The wound healing has commenced, and it's only been about 2 weeks, but obviously the foot looks great. Now, the left foot has a recurrent heel ulcer, which he's been fighting. It's more in the heel, in the base of the heel, and he's been fighting that for quite some time. He underwent angioplasty and stenting of that at the outside hospital, SFA again, but not again of the infrapopliteal. So I'm just going to go over the angiogram. I don't know if you guys can show the angiogram. Scene minus, please. So what we decided to do, minus, go all the way to the beginning. What we decided to do was we always go a retrograde up and over approach rather than the antegrade. Obviously, an antegrade approach can minus again, can easily be done. So we got access on the right common femoral artery here. We know the anatomy quite well, so we didn't bother doing an iliac angio and a bilateral lower extremity runoff like we would do normally. So what we have here is we took our catheter and we used in this case a universal flush catheter, and I think all of you out there can use whatever catheter you're comfortable with. The beauty of the universal flush catheter is that it's a pigtail type catheter which allows you to be able to inject under high pressure and thereby really getting good visualization. So the universal flush catheter is placed right now at the level of the common femoral on the left leg, and you can see here an angiogram performed shows clearly that the mid SFA stent that he has is okay, but the proximal area has a tight stenosis, clearly above 70%, and also the distal SFA has some moderate disease, maybe at best 50%. Go plus, please. So we went ahead and did a better picture because obviously that was a little saline mix. And here you can see it even a little bit better how the proximal is quite good. The nice thing is that he does very well with stents. I mean, at least this particular stent on this side, it did not reclose. Plus, please. So we went ahead and did an infrapopliteal shot, and you see here that the distal SFA in the adductor canal looks quite good. Popliteal artery has some lumpy, bumpy stuff, but nothing for him to worry about. Plus, please. And you can see as it comes down into the trifurcation, it's exactly what you expect in diabetics. Although, you know, he has, luckily for him, proximal tibial disease in the anterior tibial, which occludes the TPT, which is occluded, the posterior tibial, which is open, and then you can see here that he has a posterior tibial that reconstitute, and again you can see the peroneal artery reconstitute. So actually it's a TPT that's occluded right proximally. Now go plus, please. Then you can see as we go further down, and we didn't take a foot shot, which we'll take for you now, you can see that the posterior tibial and the peroneal do come back robustly in the foot, and you could start to see a faint anterior tibial artery in the foot. So with this guy who has a heel ulcer with I believe one of the newer grafts that the podiatrist put on, I think an apple graft or whatever it may be, on that foot, and it hasn't been healing, the revascularization of this particular territory is quite important for two reasons. One, we know that the heel is going to be very well supplied by both the peroneal and the posterior tibial artery. So here, with opening this TP trunk, we're going to be able to affect him properly in terms of being able to get enough blood to the area at need. Now, if we open this, and if we're fortunate enough to get through and open this, then I think that in the future we may consider anterior tibial artery revascularization if he does not get better. But I think having 2 out of the 3 vessels going into the foot should be enough. So our plan for intervention has been quite simple, and I just want to go over with this. Usually for infrapopliteal disease, we go with a 6 French. I do go with a 6 French 45 centimeter sheath to the level of the common femoral artery. I know that you yourself, Dr. Wiley, like to go with a coronary guide. I don't know whether you use a 6 or an 8 all the way down into the popliteal artery, but I place my pinnacle destination sheath at the level of the common femoral artery, and I find that visualization is quite good from there. Obviously, if dye is a concern, you would have to give more dye from up there versus a local placement of a guide catheter at the level of the popliteal artery, but I find it's more cumbersome, at least in my hands. So what we've done is we've got our 6 French sheath up and over. The reason we went with a 6 French sheath versus a 7 French sheath versus an 8 French sheath is because of what we're planning on doing. In this particular case, most of our devices in the infrapopliteal region will easily go through a 6 French sheath. There's no reason for us to go through a 7 French sheath at this stage because none of our devices need a 7 French sheath, and we know that for patient comfort and also growing complication rates, the 6 French is going to be better than the 7 French. Now what we normally do in these patients, just to give you a plan before we start, is we go with a coronary guide-wide system, and we treat this almost as if it's a coronary CTO. As you know, in this lab, we do quite a few coronary CTOs, and what we've started to do is go ahead and use all the tools that are available to us, and we go ahead and use a fine cross and a fielder to actually get there, and then we go ahead and use a Confianza Pro or a Progress 200, whatever the wire, whatever your CTO wire of choice is. Obviously, if you're outside America, you might be having other CTO wires, but whatever the wire that you're comfortable in doing, and then try very hard, obviously, to be interluminal and try to get through. But what I've decided to do here for demonstration purposes to all of you is to use a crossing catheter, which I think will nicely demonstrate other things that we could affect. So let me show you exactly what we've done. So here we've got fluorophade at the level of the posterior tibio-peroneal trunk. You can see that you have this crossing catheter, and I put a fielder wire right through it, right? So I'm going to take this fielder wire. It's obviously trying to get into that vessel here, so I'm going to pull this back a little bit. Take a fielder wire and put it into that posterior tibial artery, right? And then what I'm going to do is track the crossing catheter down, okay? And this is by Bard, it's a crosser catheter. I'm going to torque it to face the way I want it to face. Let's see how it torques. It's usually not a very easy torqueable catheter, but it seems to be torquing quite nicely here. So I'm going to take it, there it is, it's torquing again nicely.
So
I'm going to take it right in, I'm going to stop it right there. Now I'm going to take this fielder wire out, and then I'm going to ask them to give me the crosser catheter. Can I have the crosser catheter, guys?
So Prakash, to inform the audience, we're treating a critical limb ischemia below the knee, and you're attempting to establish linear flow into the foot, correct? To the
Correct.
area of ulcer.
Correct.
Okay.
I'm sorry, I missed that, Jose. What'd you say, guys?
Yeah, to inform the audience, we're attempting to treat critical limb ischemia, which we define as resting pain, ulcers, or gangrene. And your attempt is to establish linear flow into the foot, into the area of the ulceration.
Right. So yeah, that's exactly the point. The point is, you know, in this particular, oh, I need fluorofade. Who took me off fluorofade? Put me back on fluorofade. Inject, please. So in this particular area, you can see here that we want to work on the roadmap, because the roadmap will tell us, you know, which way to go. That's good enough for me. So our plan here is to have linear flow, because improving the inflow alone is not going to be enough in order for you to go ahead and do to heal this ulcer. And I think that's part of the strategic mistake that the other doctor, and I wouldn't say mistake, or the strategic difference between what we want to do accomplish here and what he wants to accomplish, or what he wanted to accomplish. So now what we've done is we've got the crossing catheter way down, and now what I'm going to do is I'm introducing this catheter. And how this catheter really works is quite unique. It actually uses, okay, we're just going to go ahead and reconnect the crossing catheter. There's some issues here, but the point is how this catheter works is it actually uses micro bubbles at the tip of the catheter. So you have this device here, which is going to be set up here, and I'm going to show you the camera in a second. And it's really quite easy to set up. So the device itself will be attached to a pump, which you guys can show, guys, with a saline bag. And then you can see here while our tech Pablo is setting it up along with Ricky, and you can see that as soon as they set it up with the saline and everything in it, once we introduce it to the tip of the or the cap of the chronic total occlusion, the most important thing is you don't want to push. If you don't push, what happens is that the microbubbles will slowly start to make a sort of a, for lack of a better word, a drilling effect on the cap. So you'll have this constant sort of like bubbles pounding on that cap, and once you have bubbles pounding on that cap, what will happen is it'll slowly give way and the crossing catheter will advance. The beauty of this is that it tries to be very intraluminal, okay? And the most important thing is you should try not to push. Now, if you try to push, obviously you have to give a little bit of tactile pressure in order to try to push. And we normally use it in much longer occlusions. I know a lot of people watching out there will be like, well, we could probably do this with a wire. You're probably right, you could, but I think it's more for demonstration purposes that we want to show this to you. The idea here is if we're able to avoid those collaterals that are lying around, be intraluminal, this will again help us to be able to go ahead and affect whatever therapy that we want to do on this patient. So the whole goal is to open this artery as quickly and easily as possible without creating any dissections and trying not to stent, and we'll go over that a little bit later. My goal here, if I can get away with a balloon angioplasty or an atherectomy, I'm quite happy, but if I have to stent, I will stent, and we'll talk about that.
So Prakash,
yes,
above the knee, you use
ready,
035 or 014 system. Below the knee, you stick in with the 014 system, correct?
Yeah. Above the knee, we usually use an 035 system for most of our work. Rarely we have gone with an 014 system above the knee. It's not something that I recommend or you recommend, but clearly above the knee we go with 035 systems. The only time we go with an 014 system above the knee is when we use a CTO catheter, such as the Outback or the front or the Pioneer catheter. Then we go ahead, change out once we cross, and balloon with an 014 balloon to an 035 wire, and then do what we need to do. Obviously, if we're going to atherectomize, depending on the device, all atherectomy devices that I'm aware of currently go under an 014 system. But to cross through the CTOs above the knee, we usually use an 035 system. Obviously, now they have the Wildcat catheter, which can also be used, and Boston Scientific has another catheter, which also can be used above the knee and below the knee, which also work on an 014 system. So again, it all depends how you plan it. You know, when you see a lesion, what you decide to do and how you're going to decide to plan to intervene is the way to go. So I would not go with any any fast rules. The only rule that I would use is below the knee. I definitely will go with an 014 system below the knee. I know a lot of doctors and especially surgeons do use 035 systems below the knee. I have not ever done that, and I don't really advocate anybody to do that. So I'm just placing this at around where I think the cap is. I'm going forward, and you know, I'm using a little tactile sensation with my finger to torque that catheter and keep it pointed towards. You know, the problem that we lost the fluorophate is really unfortunate, because it would have been nice to really see where we're going for me to demonstrate. Try not to move, my friend. Come forward, guys. So you can see the catheter is going to come, and I just got this guiding sheath way down there. Now I'm watching. I'm lucky enough, I'm fortunate enough to have two screens here. So I've got one screen that's not on fluorophate, and one screen that is on fluoro roadmap. So I don't know where you guys are. Come, please.
Gosh, what anticoagulation are you using, and what ACT?
I'm currently using I'm using Angiomax at this stage. Obviously, you could do this with heparin as well. So what so you could do it one or the other. What I've done is you can see clearly in the I'm looking up at the picture that's showing you. We've got the crosser catheter at the level of, say, 16, 17 on our glow tape, and we've got the guide sheath just slightly above it, maybe at 16 and a half, for lack of a better word. Now what I'm going to do, is that all right with you guys? Everybody likes where I am? So what I'm going to do is I'm just going to go ahead, and I'm just going to start drilling. You're pushing, Ray. 1 second. So I don't want any pushing here. I'm just going to come forward. Okay, now start the process, please. So it's pulsating. I don't know if you guys can hear it. So now you see it slowly starts to move. I'm not doing anything. I'm just letting the crosser catheter go here, okay? Now I'm just letting it go. Again, just slowly pulsating here, trying to break through that cap. Now I don't like where it's going there, so I'm going to stop. Okay, now can I give some dye from above, guys?
Prakash, any risk of perforation?
There's always a risk of perforation, but I think we'll be okay here. As you saw, I didn't give any pressure whatsoever. The crosser catheter started to work. I mean, anytime you're in a CTO, it's a risk of perforation. Victor, is it all right to give some dye here? All right, so we're going to go ahead and hit some dye. Ready, Cindy? Inject. Try not to move, my friend. And you can see here, we're pretty much heading where we need to go, right? It's a little bit more, I would say, not exactly where I want it to be. Don't you agree?
You want to go a little more.
Yeah, you want to go a little bit more, probably. Actually, it's not bad. I would probably be a little bit more the other way.
Yeah, very close.
So I'm going to pull back and redirect here. Okay, Ray, we're going to have to give fluorophate here. I can't see enough here. I'm going to pull it back. Well, it just seems to want to go there. So let's leave it there and see where it takes us. Okay? So go C minus here, guys. Yep. That should be actually very good. I like the way that looks.
Do you think you're subintimal, or it doesn't matter?
It doesn't feel like I'm subintimal. Let's see how this works here. So I'm just going to go on, Ray. Off. See, now I'm a little concerned on how that thing is progressing. Off fluorophate here. I'm going to walk this back, and I want to do, oops, okay. I want to do a fluorophate here, guys. Ready? Okay. Inject. The problem is the system is quite bulky, so we're not really able to see something. So I'm going to pull this catheter out. I'm going to ask for dye in a syringe. Can I have dye in a syringe?
Now, Prakash, you've clearly broken the proximal cap.
Yep.
Would you just go with a 014 hydrophilic wire?
I probably would, but I want to see what I can do here before I do. Come forward with some, oops, hold on. Dye, guys. Yep, a little more. Good. So give me fluorophate again. So actually, we're in a pretty good stead there. We were not in a bad stead at all. I'm going to continue to go with the crosser catheter. And you know, sometimes this is the process that you want to do. You want to use your noggin, you want to think about what you're doing, and you want to evaluate periodically which way you're going, you know? And we got plenty of time. We got another 40 minutes, so no reason to really rush here. So try not to move, my friend. So I'm going to go with the crosser catheter here. Ray, you need to help me here. Tell me when you guys see the catheter. There it is. Oops, going in that collateral. Yeah. There you go. Come forward, Ray. Okay. Ready, guys? Let's start again here. Now the patient may feel a little vibration in his leg. That's all normal. Off. So it goes for how long, guys, before it has to stop? 30 seconds, and then automatically stops.
And you wait how long before you start again?
Just a few seconds, and then restart. Now, the problem with this is you have a maximum amount of time that you can do this catheter. There it goes. See that? Okay, now we're in the vessel. You guys see that now?
Very
Off.
nice. Very
You
nice.
see that, how it worked? Now what I'm going to do is I'm going to go ahead. I'm very certain I'm in the vessel. Flora, please. And I'm on Flora. Forgive me. I'm going to take this catheter down. Actually, keep cross-ring, guys, for me.
Prakash, we have a question here. Is it mandatory?
Okay, good.
Is it mandatory
Stop.
at Sinai to perform angio-CT of the legs before a surgical decision of amputation and give a
There you
patient
go.
an endovascular option?
Is it mandatory to do angio-CT before what?
The question reads, is it mandatory at Sinai to perform angio-CT of the legs before surgical
300
decision
mailman,
of
please.
amputation and give an endovascular option?
You know what? I think, honestly, there are too many amputations performed at proper evaluation of the vascular system. It's very, very clear to us here, and you know, in both of our practices, and also our surgical colleagues, who are very good friends here at Sinai, to really evaluate what's going on with the vasculature prior to doing any sort of surgical intervention on patients. Obviously, vascular surgeons, especially here at Mount Sinai, are top-notch and have really become very, very, very adept at using all these endovascular techniques in order to be able to go ahead and intervene on their patients. I think in today's day and age, with the availability of catheters such as the crosser, with other CTO devices by other companies, it's clearly not out of the realm to say that you can pretty much revascularize anything. Off fluorophate, please. You can revascularize pretty much anything prior to amputation. The whole point is you would like to give the patient the opportunity of keeping their limb. We know the mortality associated with the amputation is quite high, and obviously a lot of these patients have very diffuse disease, have concomitant cardiovascular disease, which also prevents them from undergoing bypass or lower extremity bypass. Let's do a fluorophate here, guys. I don't want to see where this wire is going here. Ready, fluorophate? Actually, go low mag. So yes, in Mount Sinai, it is not necessarily an angio-CT, but definitely an angiogram prior to bypass is important. Go ahead, inject. So I just want to make sure that we're where I think we are. You can call me a little more paranoid than other doctors, but that's really kind of how I am. And right now, it looks to me that we're in the posterior tibial artery, which is the artery that I wanted to be in. So I'm quite happy with that. I'm just going to push this down into the posterior tibial, right? So now I'm going to walk this out. Now I got arterial access in the posterior tibial. And now we can talk about what we want to do.
It's important, Prakash, you made the point that there's high mortality associated with amputation. The 5-year risk of dying in patients with CLI who undergo an amputation is approximately 50%.
Oh, absolutely. I'm just going to ask Ray now to take a picture. Hang on, Ray. Okay. Inject. So you can see here we've actually gotten through. We've got a little bit of a posterior tibial artery, TPT occlusion, But if I can affect this to be open, I would gladly do so.
So Prakash, what are you going to do? You're going to balloon, you're going to stent, you're going to do what?
I wish I had everybody out suggest what to do. I mean, here, the jury is really out. I think standalone atherectomy may not be a bad option here to try to attempt to do. That may be something that we could talk about. We could talk about balloon alone versus or drug-eluting stenting. As you know very well, Dr. Wiley, I just want to refresh everybody's memory that Dr. Zeller and colleagues did a very, very nice study. Maybe you can talk a little bit about that while I decide here what to do.
Yeah.
What do you think we should do? All right. So it seems like our consensus here with our gentleman here is to balloon or atherectomize. What do you think, Dr. Wiley? What do you think we should do?
Probably a balloon angioplasty will suffice at this time, and then you decide if you want to stent, and then the next question will be what type of stent are you going to use? Drug-eluting stent, non-drug-eluting stent?
So I'm going to think a little bit out of the box here. I'm going to ask for an atherectomy device. Okay, can I have an ES plus, please? I think it's important here in terms of, for whatever it's worth, the value of debulking. Obviously, it's a short segment. I believe we're intraluminal. You saw how the catheter worked. We were not at all very aggressive in terms of pushing the catheter. We've crossed the lesion. We got an 0-4 wire down. We got a complete control. If we do, have a problem with atherectomy, either the device won't cross, or if we need to do a balloon after atherectomy, I think that's okay. Me personally, I like to avoid stenting in this particular area. I know there are a lot of people who believe in drug-eluting stenting. In my opinion, my goal with him, and I've always thought about goals of therapy prior to seeing a patient. My goal of therapy with this nice man is to heal this ulcer. Okay, and as you know, the drug-eluting stent trials that have come out of Germany have clearly shown that patency may be better in terms of their TLR, but however, the wound healing is no difference between drug-eluting and bare metal. Currently in America, and this really is not coming into my decision-making, but I want to make it clear that drug-eluting stents are not indicated for below-knee use. So yes, we're going with an off-label indication of a drug-eluting stent, although with the best intentions for our patients. And we know there are many anecdotal studies here that have shown with great patencies, even out of our own Mount Sinai with our database that we published. Yes.
So you're saying that the data that Zeller has published, in which he has decreased target vessel revascularization from 20% to 9%, using a drug-eluting stent instead of a bare metal stent, perhaps is not as important as we think, because your primary goal is not prevent restenosis, but wound healing, correct?
Yeah, exactly. I think as far as, the way I look at it, the way I teach my fellows is, what we want to do is, mag up here, guys, what's our goals, right? Our goal with this patient, my goal with this nice man is to heal his wound and make him have an intact foot and keep him pain-free. Now, I know that with 3 months, and I know your lecture is going to follow where they're going to get a lot of information, 3 months of good wound care, like he has a wonderful podiatrist who is going to take care of his leg. As long as I restore the blood to his foot and I keep this artery open for approximately, say, 3 to 5 months, this wound will heal. Now, it's a calcaneal lesion, so it may need longer time to heal. Now, if you look at angiographically on this particular lesion, you have a very short segment lesion. So you could argue with me, hey, you know what, atherectomy, balloon stent, they're all probably going to have similar patency rates. Since it's such a short lesion and the rest of the vessel looks so healthy and the runoff vessel looks reasonably good, I'm thinking that my patencies are going to be fine with just atherectomy and balloon. I honestly do not believe that there's a right or a wrong answer in this particular case. I think what you need to do is feel comfortable with whatever it is that you're going to do. Now, obviously, if I do decide to do a drug-eluting stent with you on this gentleman, then I'm gonna mandate that I treat him with 1 year of oral antiplatelet therapy, dual antiplatelet therapy. And I don't know. He's a gentleman. He's obviously a vasculopath. He may have GI issues. And if these patients stop their oral antiplatelet therapy, then they're also at the same risk for stent thrombosis as patients are with the coronaries. So I tell all my colleagues, whoever wants to use drug-eluting stents, I say, listen, you have to understand this is exactly the same as you would be in a coronary, and you want to make sure that you use the same dual antiplatelet therapy. Let me just mag up here. Okay, let's go fluorophate here, guys. So these are the factors that really play into me. I don't think I'm going to lose anything, lose anything by doing atherectomy followed by drug-eluting stent, right, if I need to. And if I don't need to, then that's fine. You know, my whole goal is to get a nice result angiographically that everybody here is going to say, okay, great, you know, this is going to stay open definitely for the next few months. So I am going up and over. So how we decide on our atherectomy device, and in this particular lesion, honestly, you can use any atherectomy device. I'm going to go with the directional atherectomy device here in this lab. This is the Silverhawk device, and this is the ES device, which is a very, very small device. Now, what we normally do is we get to this level, and what I want all of you guys to do, I know it's a TO and everybody's worried about it, I want you to just push the atherectomy catheter through. Because the greatest risk of perforation occurs if the atherectomy catheter gets stuck. So you want to go ahead and daughter it and then pull it back and see how it feels for you. Okay, it feels quite good actually. It's a little tight, which you would expect, but at the same time, you know, it's quite all right. Now what I'm going to do is I'm going to always ask for a balloon in case we do perf, right? I mean, we have to be realistic. Things do occur. So I'm just going to ask for a balloon. I'm going to ask for a 30 balloon here. And I'm just going to go with an anterior pass. I'm going to stay away from those collaterals. And whether it's an anterior or posterior really doesn't matter to me. I'm going to go up, start here, please. So I'm going to make a little cut right here. Right, very slowly, off. And then I'm going to pull it back. And I'm looking at my patient. He's smiling at me. I know he's feeling good. He doesn't have any pain. So I'm going to keep torquing. I'm going to go the other way. On, please. So I'm going to make 2 passes. Just 2 very gentle passes. All the way in, off. Now when I pull it out, if we, God forbid, have perf, he'll have a little bit of discomfort. He may feel a little bit of pain, a little bit of warmth, and honestly at this stage we don't know. So I've asked for my balloon. Now I'm going to go ahead and take a picture. Inject, please. So we're going to inject.
Prakash, we have another question here. It reads, what kind of face and neck radiation protection device is that? You look like you're in space. Can you tell us what
the
you have
radiation
on?
protection device. Well, you know, I've been fortunate enough that Dr. Sharma here has been kind enough to give us this device called what's called as zero gravity. And myself and my nurse practitioner, Ray Lascano, have been exposed to a lot of radiation over the last few years, obviously working, as you can see, we're hanging right on top of the II. Normally, Ray would have this particular device, which he did for the majority of the procedure, about here to protect him, okay? And what I would do is work like this. So with this particular device, I'm not wearing any lead whatsoever. I have no lead on. I have a thyroid shield and an eye protection for myself, but I have no lead on whatsoever. And right now, we're currently evaluating the amount of radiation that's going to me, but studies have been done on the outside that clearly show there's absolutely 0 radiation level inside this particular shield. My arms are exposed. You can see I did a complex below the knee lesion without a problem. I can freely move around, you know, and you know, it really helps because in the past, our fellows, you know, I forgot to introduce our fellow here, Dr. Burkheim, who's also here with us as an interventional fellow, and Paul, our nurse, who's been wonderful for many years with us. But the point is, there's a lot of radiation exposure in peripheral interventions, and we try to teach radiation safety, and you can see everybody here has got glasses on, and everybody's practicing good safety. Obviously, I don't, so I can talk. That's why I don't have my mask on, but majority of the time, we're all practicing safe techniques here at Mount Sinai.
So you have no weight on, correct?
I have absolutely no weight. See, what happens is if I detach, I have a little here, which goes ahead and is on.
It's a little vest, right?
It's a little vest that plugs on. So right now, right here, now I'm attaching. You'll hear a little click. I don't know if you can hear it. And now I'm in. So this is the beauty of this particular device. They're protected, I'm protected, the patient's protected, radiation levels are low, and we go ahead and work. Actually, Dr. Radio VP was the first one to get this, and Dr. Sharma was kind enough to go ahead and let us get this as well. So anyway, beyond that, let's focus on what we've been doing. Minus, please, scene minus. You can see here now, we made 2 passes with the atherectomy catheter, and look, we have a beautiful straight line flow, great flow into that vessel. Now, should you make more atherectomy passes or not? You could argue you should, okay? But to me, I'm quite happy here. I don't want to create any dissections. I'm going to go with a nice 3mm balloon, okay? And I'm just going to go up with a 3020 to say around maybe just to profile and leave it up for a few minutes. So can I get a 3mm balloon, guys?
Prakash, why not bypass? You know the data from the basal trial that randomized patients into open surgical bypass versus endovascular approach. What's your take home? And
I think that's a great point, Jose. I think bypass for this gentleman is a definite viable option. You know, but I got to tell you, when you look at this angiogram and you have a very, very short segment lesion, I think an endovascular first attempt may be reasonable. You saw here that we did not, there's no, a fem-pop bypass is not going to be the ideal situation for this gentleman. He's going to need a fem-tibial bypass, and basically common femorals to say posterior tibial is what he would have needed. So obviously you need to have adequate vein. I don't remember whether he's had a bypass. Have you had a bypass? Yes, he's had a bypass. So the chances of him having an adequate vein are not going to be there. And if you go with PTFE, obviously your patency rates also go down. So clearly, in this situation, if this does go down and we decide to go to a surgeon, if we show this to our surgeons, they'll be fine with what we've done. They said, hey, you know what? You attempted to open a short segment posterior tibial artery occlusion. You went ahead and did atherectomy followed by balloon. They may even suggest that we try, if God forbid this restenosis, to put a drug-eluting stent. And even if that fails, then if we send the patient for bypass, I think you still have not burned any bridges. So the whole point of what we do is we look at it holistically with, as far as the patient is concerned, and say how we're going to do it. I'm sorry? So we got a 3030 apex balloon here. This is a coronary balloon. So we're using a coronary balloon. We do have plenty of peripheral balloons. So we decided to go with a coronary. And again, like I tell everybody out there, this is very similar in terms of our approach with coronary CTOs. So we're going to go forward. I've got my wire down, and I'm going forward here. So again, you have to be very careful with these small coronary balloons in the peripheral, because a lot of times when you push, you just push it right through the lesion and down the toe. So you got to be very careful to make sure, and you'll see me often asking, does anybody see the balloon? And I can see it right there, so it's going down. So I'm going to push this balloon down maybe a little further, right about to that point, and just ask Ray to go up here. Go up, Ray. Now we're just going to go to profile. And what I usually do at this stage is come off fluorophane, because I really want to see the balloon expand. Okay, now I'm just seeing the balloon expand because I'm really trying to go to profile. 3, 4. Obviously nominal in this balloon is what, guys? 12. So we're going to go to 5. Go very, very slowly, looking at how our patient's doing. 6. Okay. 7. I do believe this is a 3-0 vessel, Jose. 8.
Okay.
9. Still not happy. Starting to look a little bit better to me. 10. 11, 12. I am going to leave it at 12. Now I'm going to put a timer on. And we're usually very aggressive in terms of how long we leave these balloons up. So and that's part of the beauty of giving bivalve-Rutin on these patients. You've given bivalve-Rutin here, and we go ahead now. We can leave the balloon up for the next, I'll probably leave it up for at least 5 minutes to see whether I can effect a nice result on this patient. So the beauty of bivalve-Rutin is, well, so far we've been talking for the last 40 minutes. We've not, we've checked an ACT. Our ACT is adequate, as our nurse Paul said. And now we don't need to check it ever again. We've got the drip going. In the old days with heparin, we'd have to go back and forth. The other thing in terms of future technologies for here is the use of drug-eluting balloon. As you know, drug-eluting balloons. Can somebody check my phone, please? The use of drug-eluting balloons, may revolutionize this particular field. As you know, drug-eluting balloons are being studied right now in multiple above-the-knee trials and are being used in Germany. So drug-eluting balloons may affect this particular area very well. So a prolonged inflation would say a drug-eluting balloon with paclitaxel may be the final solution for problems of restenosis below the knee, but who knows? Obviously, everything has its own trouble. So but here, as far as our technologies that are available, this is what we do.
Prakash, so you think that the advent of this new technology, the drug-eluting balloons, the drug-eluting stent, may change the paradigm of treatment of below-the-knee critical limb ischemia, that is, treating patients who have perhaps claudication with drug-eluting balloons and drug-eluting stents?
Well, my humble opinion is that I think that stenting has never really worked in this particular area, and I think bioabsorbable technology may be something that's exciting in the SFA as it is in the coronaries. But I think below the knee also, although fracture is less of a problem below the knee, to leave a device as in these vessels, in these small vessels, may not be good. So if we have a bioabsorbable technology below the knee, or if we have a drug-eluting balloon that works below the knee, I think it helps. But Dr. Wiley, I really feel, I think like most of us who do a lot of these cases, we do about 1,500 cases here at Sinai, and that these particular lesions are very, very difficult, and we just use tools in the toolbox to be able to affect a good outcome on our patients. So at this stage right now, till we get that holy grail and we solve the problem of restenosis, but we do have effective therapies for wound healing. And wound healing, again, is important. Blood supply is the most important part of wound healing, as well as good wound care. So I've done my part with getting the blood supply for this gentleman, and now with good wound care, he should heal up nicely. Now this balloon's been up for 2 minutes and 30 seconds, so I'm going to ask Dr. Burkheim to go down to half pressure now. This is the technique, go down to 5. This is a technique that we learned from Dr. Sharma, where really if you have any dissection flaps, you just want to tack it up with a little bit lower pressure, go to 5 atmospheres for another 2.5 minutes. So this way we alleviate the complete obstruction, and we'll tack up any small dissection flap we may have. The second thing, the nice thing with the slow balloon inflation that you want to learn from what we did is basically to realize that what you want to do when you inflate slowly is to avoid that abrupt pop of the vessel. Now, when you go slowly, you avoid that pop, and I believe when you see that angiographic balloon, then you know that you really ruptured that plaque and unlikely caused a dissection. Slow, sustained inflations and slow and prolonged pressures, you will clearly be able to tack that up. And the whole idea I'm trying to achieve here is try to get away without putting a stent in this gentleman. Now, I got to ask you about that proximal lesion. Now that we've fixed the distal, should we go ahead and open that up? And what would you use to open that up?
That's a good question. We always try to open or improve inflow, so I think it would be reasonable. You started using atherectomy below the knee, worked quite well. I don't see no reason why atherectomy cannot be used at that proximal.
That's a great point, but
SFA.
we went with a 6-French system, and again, part of the planning of the procedure is what we talk about, because I felt that all we're going to need is a 30-millimeter stent up top. So a 30-millimeter stent, our primary patency rates with the 30-millimeter stent are phenomenal. So what we could do is we could do a short balloon angioplasty, or we place a stent and then do a Meiweisen's technique of putting a balloon within the stent struts and then not letting the balloon come outside the stent and balloon post. One or the other, doesn't really matter. And I think regardless, our patencies with a short stent are going to be quite acceptable. Down, please. So we're at 5 minutes. We're going to go down. I'm just going to pull this balloon back and ask Dr. Burkheim to give us a nice injection for us. So I'm just going to pull this back a little bit. And one of the things I'd like to just share with you is just keep the balloon at the level of the SFA, because you don't know whether you've perfed. I mean, anything can happen, and you don't want to have miss anything. So we're going to inject now. So as Dr. Burkheim is injecting, you'll see beautiful flow, right? So you basically have a new vessel that's formed thanks to the technology that we have available. So I'm very happy with this. I took an artery that's occluded. I affected it. I crossed it with a crosser catheter very, very effectively without a problem. And now I'm in the posterior tibial. I'm going to go, as ready to go, low mag here. Okay, now I haven't perfed, so I want to take a better picture. I'm going to walk this balloon all the way out.
It's a very nice result, actually.
So I'm going to walk this balloon all the way out. Ray's gone to low magnification. Right, a little bit lower, Ray, for me. One more. Okay, now shutter in. Now, one of the things I also want to emphasize, shuttering in is very important to reduce your radiation intake. As much protection as you use, proper technique is also important. So we're going to inject now. So we have a little bit of a dent, which was probably there before. I'm not probably going to go after that. It doesn't look more than anything other than a bend in the vessel. And now I'm going to go ahead and go lateral here to really show you a nice picture of his posterior tibial artery. I'm going to need to raise the table. Okay. Okay, I guess this is the best we're going to get. Inject, because we've got a lot of stuff in this room right now. So we can see here that's just gauze over there. Now you can see you have a nice direct flow into the posterior tibial. Peroneal also comes down. We haven't lost the peroneal, and the anterior tibial comes down. So I'm just going to further evaluate that lesion up top just to make sure, because all this work, I don't want to leave something that I could easily treat. Mag up, please. Mag up one more. A little higher. Mag up. Okay. Shutter in, please, now. Okay. Ready? Inject. And Jose, that's nothing but a bend.
Yep.
I'm not going to touch that. I don't
I-
want to create.
I agree with you.
I don't want to create any barotrauma.
I agree with you.
I've affected a nice result on this nice man. Got no dissections that's angiographically visible. There's some step downs that may be there, and that's actually just a branch that's occluded that you're seeing. So I'm not really at all worried about this particular result. I'm fine with it. Now I'm going to look at the proximal, and then since we have a few minutes, we can just go ahead and do that online as well, and then decide what we're going to do. So I just want to go ahead, go forward here.
So Prakash, to reiterate, in the management of this patient with critical limb ischemia, your approach was to ensure linear flow to the ulcer for wound healing, not concern about restenosis, but
moderate.
wound healing, correct?
Pretty moderate. Yeah, exactly. Now looking at this on a high, magged up quite well. This looks like moderate disease,
Yeah,
Jose.
doesn't look that bad.
Yeah, it doesn't
I
look
agree
that
with you.
bad. It looked. I'm going to take obviously multiple angiographic views as we teach our fellows to make sure, because SFA lesions can be very eccentric. So we want to go ahead and look at it, and obviously you have a lot of dye lying everywhere. I'm going to apologize for that. So you can see here, just going to mag up. Sorry, you getting any cramps in your legs? No, good. All right. So one more picture. So here you have a lot of overlaps. You can't quite see. I'm going to go to the other view. Obviously, the views for the SFA really are effective are your ipsilateral 20 or 30. So this should be a nice view here to tell us. Yeah. So I really am not impressed.
Me neither.
I
I
really
agree
am not
with you.
impressed. So we've impacted a nice therapy on this patient. We've got through. We showed you. I'm going to pull the wire back now and take a picture without a wire. This is a very important thing, actually, that I should stress. Always take a picture without your wire, because obviously if you have a dissection flap holding something up, hold it up, and then the moment you pull out the wire after the case, the patient will lose the pulse. So it's again important for you to go ahead and practice good technique and pull the wire out. And then you can give vasodilators, but in this case, we have a really good flow. Again, we're going to bring the II all the way down, open this up, and take a nice picture. There you go. Don't move your legs. Your last picture. And there's your final result, which I think is
really
quite
good.
acceptable.
Yeah,
There is a little bit of
absolutely.
recoil, but I think it's also a little underfilled right now. If I mag up, it'll look really good. Bray did give a little less dye because, obviously he's doing well. Now, the last thing I always do, the final acid test, is a pulse. I'm going to have Paul take a pulse and make sure that we have a posterior tibial pulse that's palpable. I'm going to move it down, make it a little convenient for him so he doesn't have to do this. We try to make sure that when the patient leaves the lab, they have a palpable posterior tibial pulse, because if we don't have a palpable pulse, we've not really affected enough therapy. There is a significant amount of recoil that occurs in these vessels, so a little bit of waiting and a little bit of prudence in actually palpating a pulse and feeling the pulse before you go may be worthwhile. A lot of times it takes multiple attempts, 2-3 people to feel the pulse. Paul's got a pulse. He's a great nurse. And so now we know we have a palpable pulse, which we didn't have prior to the procedure. Now, how we're going to survey these patients is extremely, extremely important. Now, what's going to happen to this nice man is he's going to go upstairs. We're going to hydrate him. We're going to go ahead and get wound care to look at him here. ID, make sure if he needs antibiotics to be on antibiotics. And then we'll go ahead now and then decide. I'll call up his podiatrist, let his podiatrist know what we've done. And I will see him within a week at our outreach clinic in New York, one of our boroughs in New York. We'll see him in the outreach clinic. We'll see how he's feeling. Clinically, two to three things will occur. One, he may have some edema that may be problematic at the ankle, which again because of the direct flow. But what we're looking for is relief of pain. So sometimes when you have edema and stasis because of his previous bypass removal of the veins, at that stage you may want to be careful for overlying cellulitis and infection, which could occur. So you do want to see this patient rapidly. You want to see how they're doing and see how he's doing. Now this patient, again, I followed him and we have a very good relationship. He will call me if he has any sort of problem, so I know he's very reliable in that manner. But it's important to impart to your patient some of the things that they can expect. As far as other techniques for doing what we did, obviously a simple wire technique may be sufficient in order to be able to do it, but I wanted to demonstrate the crosser catheter and the ease of use that it has. Obviously, it's not the holy grail. Obviously, it's expensive, but at the same time, you know, we're able to do atherectomy. We're able to get this done. I think that's about it. Ray, anything else to add?
Prakash, with the intent to educate as we usually try to, I'm just going to reiterate what you teach our fellows. In patients with claudication, you do not want to treat below the knee disease because of the risk of converting a claudicant into a critical limb patient. However, in patients who have below knee disease that do have critical limb ischemia, which is defined as resting pain, ulcers, or gangrene, we treat. But the goal is for limb salvage.
I think certain paradigms are changing. I know people are very aggressive below knee for claudication when they've failed all different medical therapies. You know, the classic teaching, as you know, is that the sural nerve, the sural branch is a branch of the geniculate artery. So obviously is a branch
of the posterior.
Posterior tibial. So the whole point is that, you know, above the knee is usually causes claudication, below the knee causes ulceration. Again,
Right.
You know, I think times are changing. I think people are very aggressive. I'm not saying that what's right or what's wrong. I just think that you need to approach it on a patient-to-patient basis. The bottom line is our job here is to make our patients feel better, not to make them worse before they leave your lab. They need to come into your lab and leave better than they came in, and with you having effective positive therapy on this patient. So, you know, this is a nice just demonstration for all of you out there and again, it's not, there's multiple ways to skin a cat. This is not the only way. So I just wanted to just demonstrate this, and I thank all of you for your attention. I thank Ray. I thank Dr. Brookham. I thank Ricky and Pablo. Pablo was kind enough to come in here. He's our lead tech and set this crosser catheter up very quickly. Thank you, Pablo. And obviously Paul, our outstanding nurse, for all their help. And you, Dr. Wiley, thank you so much for, again, stepping in for Dr. Dangus, who took a vacation, well-deserved vacation, and we'll be back for the next month.
Prakash, before we close, I'm assuming that you're going to do a closure device in this patient. If you would have done an antegrade approach, what would you do? Would you try to close or what?
Well, as you know, we talk about this often. You know, the antegrade approach, really closure devices, I believe, if I'm not wrong, are contraindicated in that place or have not been studied in that particular technique. Ourselves, you and me, have closed antegrade approaches very successfully. But again, obviously, you know, you do run the risk, probably a little bit higher risk than you would of closing the vessel if you don't follow proper technique. You know, that's a great point that you brought up. In this particular case, a lot of people would have gone with an antegrade technique. We find here with the newer devices and the coronary wires and the coronary balloons, to go up and over, retrograde really works quite well. We also feel that the device lengths are very important in making that decision. If we have a 6'7" gentleman who has a toe ulcer and we're going after a dorsalis pedis, at that stage we'd be forced to go antegrade versus going up and over. So we look at all these things prior to making our decision. But to answer your question, I believe that antegrade sticks can be closed, but they have to be closed with great caution. And I do believe that you do probably impact a higher complication rate on these patients. As I'm not aware, I don't know if you are, Dr. Wiley, of any studies that have, or publications that have shown safety and efficacy rates. But I'm very certain that the device companies, especially Perclose or Angiogram, would not recommend routine closure of antegrade sticks with their device.
Yeah, there's only case studies, but no,
Right.
no large series.
I just want to show that again, we have the supercore wire down. It's important to now come up, pull this back over the stiff part of the wire. You can see it has a very narrow bifurcation here. And this is where the catheter flick occurs, and you can have trash foot. So you want to make sure that you pull this out over the stiff part of the wire. I know you yourself use a dilator. I just use the stiff part of the wire. Now I take this wire all the way up, you know, as far up, and I'm fine with that. You can see his bypass surgery that he told me he had. I'm just going to walk this out here and let it bleed out profusely, and then I'm going to put pressure, and I think we're done. It's exactly 5 minutes to 9. I do appreciate the audience for logging in and spending this their precious time with us, and I hope they all learned something. So thank you again, Dr. Wiley.
Thank you. I'd like to inform the audience that our next webcast will be on September 26th. Again, our next webcast will be September 26th. This Presentation will be followed by a talk that will be done shortly. Thank you.